morning, good evening.
I have all pleasure today to present this work entitled Cervical Pulpotomy in Mature Permanent Molar. Cervical pulpotomy in mature permanent tooth with Carious exposure, a 3-year follow-up case report. First of all, we are going to have a brief introduction. Management of Carious teeth with signs and symptoms indicative of irreversible pulpitis by pulpectomy is traditionally invasive, but emerging evidence suggests cervical pulpotomy as successful treatment which aims to preserve the vitality of the pulp and its defensive functions against bacterial aggression. The aim of this work is to present a successful management of irreversible pulpitis with Carious exposure by coronal pulpotomy in second mandibular permanent molar with 3-year follow-up. Now I will present the case report. A 30-year-old female patient was referred to the Department of Endodontic with a chief complaint of pain and the second right mature permanent molar. On clinical examination, there was presence of a large deep Carious lesion. There was no history of swelling or medications. There was no tenderness and percussion. Diagnostic tests revealed lingering pain to hot and cold tests. Radiographic examination revealed presence of a large radiolucency in the coronal portion of the involved tooth approaching the pulp with normal periodontal ligament space and lamina dura. There was no periapical lesion visible on the radiograph. After complete clinical and radiographic examination, a diagnosis of irreversible pulpitis was made in the involved tooth. The patient was treated with complete coronal pulpotomy with placement of MTA in the pulp chamber and resin-modified glass ionomer liner and the tooth restored in first appointment. The crown was restored with composite and long-term outcome revealed a success of therapy and at 1 month, 3 months, 6 months, 1 year, and 3-year follow-up. So, after 3 years, clinical findings showed absence of any periapical pathology with healthy soft tissues around the tooth and normal percussion and palpation. Intraoral radiography revealed normal periodontal ligaments. The tooth was fully functional and the patient was asymptomatic. Now I will discuss the success of vital pulp therapies and biomaterials. The success rate of vital pulp therapies in mature permanent teeth ranges between 99.4% for partial pulpotomy and 99.3% for full pulpotomy. The histological studies revealed a complete dentinal bridge with radicular part remaining vital and free of inflammation. In teeth with irreversible pulpitis, the success rate of coronal pulpotomy was highest, 95.5% at 12-month follow-up, as compared to direct pulp capping, 94.7%, and miniature pulpotomy, 91.4%. Systematic review, including different types of study designs, prospective, retrospective, randomized control trials, found 95.4% clinically and radiographically success at 12-month follow-up. Concerning biomaterials, different materials are used in different vital pulp therapy. Calcium silicate cement, mineral trioxide aggregate MCA, and the calcium enriched mixture cement. Hydraulic calcium silicate cements revealed their superiority to calcium hydroxide as pulpotomy agents. In a systematic review by Leal, the clinical and radiographic success rate at 12 months with MTA pulpotomy was higher than calcium hydroxide pulpotomy. Taha et al. Reported the success rate of 100% in 1 year and 92.7% at 3 years in their study with regard outcome of MCI pulpotomy in mature permanent teeth, in which pulp was exposed due to caries. Recent developments in bioactive materials have been found to be very useful in the treatment of irreversibly inflamed pulpal tissues. To summarize, coronal pulpotomy is less invasive, cost-effective, simple, and less time-consuming for patient and the dentist. The high success rate reported in all systematic reviews for pulpotomy suggests that this procedure may be an alternative to root canal treatment in teeth with irreversible pulpities. Thank you.